Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds, Premier Education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great pleasure for me to invite Professor Hutan Ashrafian, who is a professor at the Global Health Innovation Institute at the Imperial College London, also a surgeon, to talk to us about cost effectiveness of robotic surgery. Hutan, over to you.
Well, Eric, it's lovely to be here with you, and thank you for the very kind introduction. I'd like to just present some thoughts on what a lot of you are doing, which is robotic surgery, and how cost effective it is. These are my conflicts. Just to say that my major conflict is that I am married to a thoracic surgeon, which is an interesting thing. Before I start, I always talk about unashamedly some of my own work. And the reason I present this to you is to say that when we talk about robots, people have thought that it came from the 1900s and the 2000s when the word robot came from this word by CAPEC. The reality is that if you were to watch Christopher Nolan's recent film on the Odyssey and look at the work of Homer, it's very clearly there is in it, in the Bronze Age ancient Greece, the presentation of how automated robots were used in the Trojan War and subsequently, particularly in the building of Achilles' armor by Hephaestus. So there is a known history of robots that goes back into antiquity, and it just so happens that as surgeons we've decided to adopt this technology relatively in our recent past. But the real exciting thing about robotics in surgery is that it is clearly a new force for aiming to get better clinical outcomes. And importantly, what a lot of people haven't always talked about as much is that this is also a technology that is designed to be more usable for the surgeon. So to enhance your patient's quality of life, it is not only about just the process of that quality of life, but also seeing how that a surgeon's day can be optimized, both ergonomically, but also in terms of physically and time. And so we have seen an unprecedented rise of this technology over the past 20 years globally. There's been a 28-fold increase in the adoption of robotic surgery. And in the world of thoracics and cardiothoracics, it's been about, specifically thoracics, it's been about 14.5 times increase in the past 10 years. And that makes thoracics the fourth largest user of robotic surgery after urology, gynecology, and colorectal surgery. But interestingly, in the past 10 to 20 years, the rate of adoption in thoracics has been the second highest user. But that said, there is a gap in the evidence of robotic surgery in terms of cost effectiveness, and cost effectiveness tends to be the big driver for a health system or a country to adopt a new healthcare innovation. It so happens that pharmacological interventions are heavily scrutinized with cost effectiveness, and as a result, there's a large drive to adopt some of them based on cost effectiveness, whereas the actual data for robotic surgery is a lot more sparse. And to understand this problem better, I and my team have performed an umbrella review of all robotic surgery, really to see if robotic surgery is cost effective compared to other surgical treatment modalities, and also specifically talk about it in terms of thoracic surgery. But just also from a contextual point of view, to highlight what are the most common economic metrics used and what seem to be the key drivers of this cost effectiveness. This is some work I did with my team and my lab, and to highlight that actually in the world of systematic reviews of cost effectiveness, we went through 506 papers, and there were 27 papers in totality in this field. For someone like me who does a lot of work in this type of space, that's actually comparatively a very small number of papers if you look at that in totality. And health economics is seen to some extent by us as a group of physicians and surgeons and oncologists and health practitioners, to some extent as hocus pocus. And to try and alleviate that problem, we've come up with a framework of an A, B, C, D, E, summarizing the 5 key domains that any health economic analysis should have. And hopefully I can convey that to you so that we can digest some of the results in a way that can make use for us and our decision making. So the A in my A, B, C, D, E is any economic analysis needs to have some core assumptions. And those assumptions are, what are the comparators that a robotic surgical platform is compared to? A, what is the robotic surgical platform? And B, what is it compared to? Is it compared to VATS? Is it compared to laparoscopic surgery in the general world? Is it compared to open surgery? Is it compared to radiotherapy? 2, how is the analysis done? What are the analytical perspectives? With what context is that aimed? Is it comparing the costs of a tool from a hospital point of view, from a societal point of view, or from a payer point of view? In the NHS here in the UK, we have a single payer system, broadly speaking, whereas in the United States, for example, there is a panoply of different types of payers there, whether they're insurance-based or non-insurance-based or out-of-pocket paying. What is the follow-up time? This is a large variability of when one decides to set the analysis of any particular tool. Do I look at a 5-year window? Do I look at a 1-year window? Do I look at a lifetime window? And then lastly, what are the types of analysis done? Many of the studies in this space are based on projections and simulations versus actual real-world data. And of course, real-world data is typically a better reflection of what goes on because it's real world, but that data isn't always so easy to come by, and as a result, simulations are used as a proxy. In terms of the B, which is the second element that any cost-effectiveness analysis should have, of course, it depends on the specialties included in that. I'm speaking to a bunch of very expert cardiothoracic specialists, but of course, urologists and colorectal surgeons, hepatobiliary surgeons, gynecologists are very big users of robotic surgery, and many of the papers in this field would be derivative of those specialties. And also, when we talk about economic evaluation, what are the financial and reimbursement models we're talking about? Is it a value-based model? Is it based on bundles? Is it based on add-on tariffs, or is it based on risk sharing? Each one of these has its own needs and wants, and as a result, when one is comparing two cost-effectiveness studies, having the same financial reimbursement model in the background is critical, because simply you can't compare two different models at the same time because they give you very variable results. This is the bit that everyone is more familiar with, is what are the cost components? What are the actual total costs? What are the capital expenditure, what we call CapEx costs, which is what, for example, what is the cost of the platform? What's the cost of the robot itself, just to buy it outright? What is the operating expenditure, the OPEX? How much is the cost of the consumables? And what are the overheads? What are the indirect costs? What is the cost for training staff, training trainees? What are the costs of the actual instruments and their sterilization? It's important to note that much of the costs that are absolute costs, and what a lot of people would say back of the envelope analysis on simple cost analysis, only compares costs, and it doesn't necessarily compare health outcomes. So it's important to always have an index of what your cost is indexed to. And that takes me to what are the determinants. This is a D of utilization. And typically, people use length of stay, complication rate, operative time, and learning curves. Now, occasionally people use other determinants of utilization, and it's important to index to these because clearly these are important for us to make decisions on our patients and when we want to adopt a new technology. That said, these are only a handful of all the relevant clinical metrics that would be useful for us. But at the moment, many of the studies that are in this space are limited to these 4. So what are the actual economic types? This is where people start thinking that, you know, there is a large set of terms that they're not necessarily comfortable with. And so let me try and break those down for you before I go to the actual data of how these robotic platforms fared in terms of cost effectiveness. People talk about incremental cost effective ratio. Simply, that is a ratio of the change in cost over the change in an effect. And so you have to have a ratio of two things to be able to achieve a cost-effective ratio. It's a change of one thing with a change over change of another. In cost per quality or cost utility, that change in effect is the change in health. And that change in health, people use the value of equality, which is essentially 1 full year of full health. And so when you look at a change in cost, it has to be indexed to a change in the metric of 1 full year of full health. That's what the quality is. That then can be used on different health systems where there is a threshold of willingness to pay. So what is the actual cost that someone is willing to pay for a particular extra or year of full health? And based on that willingness to pay, then the maths can be done on an incremental net benefit of, is that cost associated with that ratio appropriate for my willingness to pay? So those first 4 elements are designed to index to health outcome. That said, quite a lot of work in this space does not directly index to health outcome. It makes an assumption that robotic surgery or VATS surgery has comparable health outcomes, and they look at 2 things, which is just the budget or the cost minimization, which is simply looking at the actual robust numbers from expenditure, having an assumption of what health outcomes is, rather than indexing to health outcomes. So budget impact analysis and cost minimization analysis, one looks at how impactful is it to my set budget. I have 20 million a year for my health system. How much does this new robotic program over 5 years impact my budget? And cost minimization is, I'm going to actually look at the numbers and say, if robotic surgery costs 5 million over 5 years and VATS costs maybe 4 million over 5 years, what approach should I be taking for my patients, assuming they have a set health outcome? Whereas cost per quality and ICERs are designed to look at how each different arm fares in terms of their clinical outcomes. And the big question for us as a group is, what should we use as our proxies to put into our model for that perfect year of life? Does it only include length of stay, or can we actually include other variables as well? I hope that was something that I explained adequately for you, because I'm now going to go into just some of our results, just to say that most of the studies in this umbrella review were multi-country. Only a handful were in 5 countries. Most were from an analytical perspective of a hospital and didn't really include societal benefits. That includes productivity and patient satisfaction working at home or working in industry. It only looked at the hospitals. The time horizons were more or based on a projection, and only 4 studies actually looked at actual follow-up time rigorously from a real-world evidence point of view. As you'd imagine, most of the studies were neurology, because that's the big, heavy user of robotic surgery at the moment. And sadly, there wasn't one big systematic review on thoracic surgery. My team are working on that right now, and hopefully we'll be able to share that with you at some point in the future. Just to say that in terms of quality, only 2 out of 27 papers have the highest quality, and a third of them were of critically low quality. So there was a large variation here, sadly. In terms of comparison, and this is just top level before I break down into real numbers, compared to open surgery, only 2 studies said that there was a decreased cost with robotics, of course. And there was a handful of studies that looked at minimally invasive surgery compared to robotics. So the vast majority were either laparoscopic or VATS compared to open surgery. The absolute costs, just to give you a feel, for robotic surgery ranged between just under $2,000 per case to $64,000 per case. For VATS or laparoscopy, it ranged between $441 to $55,000, and open surgery ranged from $960 to $42,000. Just to let you know that most people use dollars as their metric. A lot of the papers do come are international, but they use American dollars as their base rate to compare against. But of course, that doesn't tell you too much, right? Simple cost is not telling you everything you need to know. So in terms of some of the clinical outcomes we used in terms of the determinants of utilization, length of stay for open was a median of 16 days compared to 12 for robotic surgery. Length of stay for minimally invasive, whether it's laparoscopic or VATS, was 14 days compared to 12 days again for robotic. In terms of operative time, robotics tend to be longer. So open robotic was in the order of 120 minutes median versus 100 minutes for open surgery, and for compared to laparoscopic or VATS, they were almost parity. There were in terms of median time, although robotic did tend to be a little bit longer. And the range was, for that particular case, it was a range of 78 to 585 minutes compared to 75 to 430 minutes, which, depending on how you appraise that, whilst statistically was significantly longer, wasn't significantly longer in terms of an impact on actual health systems practice. There was a significant decrease of complications with robotic surgery, but the way that this was measured across the different studies wasn't uniform. And so there wasn't a simple metric that one could meta-analyze to say that complications were this much lower in robotics. But it was noted that it was absolutely the case that robotics across the board, whether compared to open or VATS or laparoscopic surgery, was almost uniformly better in terms of postoperative complications. That said, in terms of the actual cost effectiveness here, 12 studies talked about ICERs, 11 had a cost utility analysis, only 18 out of 27 actually had all the A, B, C, D, E framework that I had mentioned to you, mentioning all their assumptions, their timeframes, etc. 4 talked about incremental cost, and 2 did budget impact analysis. And overall, what did we find? Well, we found that actually robotic surgery was definitely more favorable than open surgery, but it was more nuanced when it came to minimally invasive laparoscopic surgery, and it was more beneficial in terms of finances, where there were longer timelines and time horizons of follow-up. That means typically 5 to 10 years. What we'd call the gold standard cost effectiveness ratio is for laparoscopic versus open prostatectomy, radical prostatectomy, which is at about £4,000 to £5,000 per quali, whereas in places like oropharyngeal cancer, the results were conflicting, and actually radiotherapy seemed to be almost equivalent in terms of cost effectiveness. But there was an important thing to say, that in terms of a volume effect, the cost effectiveness could be improved specifically by increasing volume in a center, so that, for example, in a prostatectomy setting, the cost effectiveness per quali is £106,000 in 50 cases per year, but it drops all the way to £18,000 to 200 cases per year. All right, so how does this actually map to thoracic surgery? Well, these are 4 studies that have been done in this space. Many of them are mainly lobectomy, although 1 or 2 of them are actually lobectomy, segmentectomy. Just to let you know, that for context, the threshold for a cost effectiveness ratio is somewhere between 25 to 35,000 per QALY for NICE in the United Kingdom. So a cost less than £25,000 per QALY is considered very good, whereas in the United States, that same figure is 100 to 150,000 pounds per QALY. And a study, for example, in Chen showed that robotic versus open surgery had a cost effectiveness of about $10,000 per QALY compared to open surgery, whereas compared to VATS, it was $80,000. Now, it only achieved that sub 30,000 cost per QALY value with a 21% probability. So depending if £30,000 is the threshold to be cost effective, it wasn't cost effective for VATS, but A, it depends on the threshold, and B, it depends on the kind of clinical outcomes that you use. If you look at the work on Raval, it was quite clearly cost effective over 12 months. That cost effectiveness was interesting because the QALY that it improved was only 0.012. What does that mean? It means that it actually gave 4 extra days of complete health. And so, yes, it was significantly cost effective and it was better than VATS, but the QALY wasn't that significantly raised. Nonetheless, it was still cost effective, right? An interesting study by Hayden from the States was that from a healthcare perspective, i.e., if you talk about hospital costs and health system costs alone, the cost per QALY was $180,000 per QALY, which is, you could argue, wasn't cost effective. But actually, when they included patient time, travel, caregiving, life productivity, that cost per QALY actually dropped dramatically. And so this was the big lesson here, that although, okay, it might not be cost effective supposedly at a health system level, if you actually included higher numbers of variables about the patient's journey, suddenly the cost effectiveness became quite dramatically different. And so again, in a more varied settings of both lobectomy and segmentectomy, the Welsh HTA model did show that the cost per QALY in the UK was about £38,000. But if it was focused only on lobectomy only, this is work from Zoo, then it was just around 5,000, just over £5,500 compared to that. But that doesn't really tell you everything you need to know, right? Because the outcomes, as I said, have been based on a handful of metrics. So in the world of thoracic surgery, of course, neoadjuvant therapy has led to a variability between VATS conversion and robotics conversion. And so that differentiation should come into any cost model that you have. RATS is significantly better from a number of meta-analyses at lymph node dissection. And as you would know better than me, there's been an increase in sublobar resection in the wake of lung cancer screening programs, which again in itself has changed the landscape of the clinical outcomes in robotic versus VATS surgery. Just to say that, of course, the data that should be used for here, and this is from a meta-analysis by Huang et al., is that it's not only looking at operative time, blood loss, and conversion rates, which conversion rates has been about parity. I really want to highlight that you need to delve into more than the basic variables outcomes for a health system to really talk about cost, because the cost, when one decides for those costs, isn't only the health system paying, it is actually typically funded from multiple other sources, whether it's insurer, whether it's the state, etc. in the United Kingdom. When we looked at incremental costs, again, this is focusing predominantly on prostatectomy data. The results of robotics to laparoscopy were in the order of $973 to $1,400 higher, but that cost premium did drop with increased numbers of volume. And again, cost neutrality was reached when over 200 cases were done per year. Again, absolute costs, and remember, this is no longer cost effectiveness ratio, but this is purely absolute costs in terms of thoracic surgery, show that the cost of RATS versus VATS from the 7 study review, which was both lobectomies and some segmentectomies, had about a 54% increased cost. In terms of operative cost, in terms of robotic supplies, of course, was a lot more than VATS, but overall, the total cost was only about 25% higher. And so that's, when we're thinking about it in terms of your specialty, I'd say that is something that seemed to be digestible by health systems. In terms of the Bravo study, which is a Lobectomy study, RCT, the 90-day costs were quite comparable. In high volume centers, the difference between VATS and RATS was non-significantly different. And in terms of mixed lung resections, there tends to be a little bit of a higher cost for robotics versus VATS, but actually it is increasingly recognized that the incremental benefits of the robotics can be higher. This is, again, there isn't any, sadly, for thoracic surgery, but in terms of the 5 to 10 year horizon for robotic versus open prostatectomy tends to be favorable to the tune of $7,000 in high income settings. But interestingly, available in middle income settings was only $2,500 or just under $2,200. So the last thing I'd want to talk to you about is how these things impact budgets. About 5 years ago, or maybe, sorry, 10 years ago, the budget impact on having robotic surgery based on Canadian dollars was something in the order of just under $1 million to over $3.4 million over 5 years in Canada based on capital costs. Remember that there was an assumption that the robotic surgery was equivalent to the laparoscopic surgery. Actually, that has dropped. And so the budget impact has, over that time, has only been a difference of $1.14 million, which is actually considered to be quite acceptable by many health systems. And the main drivers for this were both procedural volume and the disposable cost of the equipment used. So in summary, I think the things that I'd really want to discuss with you are, one, the evidence in this space remains highly heterogeneous, particularly in thoracic surgery, and more work needs to be done, clearly. It is evident that longer time horizons do better reflect the outcomes in this space, but also better capture the real world effects of the spreading of capital over time. Willingness to pay threshold is highly variable and therefore results in high income countries and middle income countries differ based on their utilization. And one thing, which is one elephant in the room, is of course cost per quality tends to favor younger patients, which is something that, whilst it's not uniform, is relevant to the thoracic surgical practice. Now, that said, I think one major element here is if one only considers the payer perspective, which is the hospital or the insurer's perspective, the costs don't take into account much of the real world elements of how much this changes a patient's life, how much it changes their productivity, how much it changes their caregiver needs, how much it changes the realities of re-immersing oneself back into a day-to-day existence. If one is able to accommodate those societal costs, it seems that in thoracic surgery, but across the board, robotic surgery tends to seem to have a more favorable outcome in terms of cost effectiveness. And we might be missing this in our studies as we work on it today. Secondly, cost neutrality is something that is achieved typically at 150 to 200 cases per year, but that does remain relevant to the platform that is used. Of course, there is a learning curve effect, but a lot of studies, and that learning curve effect isn't just the learning curve of the surgeons themselves, it is the learning curve of the health system, of the operating team, etc. But that is typically at over 50 cases. But of course, at over 200 cases, it tends to be shown to be universally beneficial. One way of saving money and being more cost effective is to have robots working in multi-indications. Many of you will already do. Increasingly, I think this research in this space should not only focus on what was classically seen as the clinical outcomes of utility, length of stay, operative time, etc., but increasingly those are not only the patient outcomes, but something that I think hardly any studies have looked at, and what we find in our clinical practice, which is the actual case complexity and the actual surgeon need, so that a surgeon who has spent doing for operative cases with robots at the end of the day is less fatigued, has less cognitive burden, and has less physical injuries, and this is something that people haven't captured so much, than a surgeon who's had to do this robotically. The prostatectomy surgeon will tell you that a laparoscopic radical prostatectomy is a marathon, whereas doing it robotically, you sit down with your coffee and able to operate. So it's taking the patient's outcomes, but in their real world setting directly, but also what the surgical needs are, and then adding that to the needs of the health system. I have to say that my talk has been very focused on robotic thoracic surgery because you have been fast adopters, right? But the robotic cardiac surgeons are coming through now. So I guess in the next 5 years, there'll be more of you wanting to talk to me about this as we move forward. That's some thoughts on this space. Happy to take any questions, and I'm very grateful for your time.
Thank you very much for an amazing presentation. Maybe I'll start with one or two questions for you. For the NHS, which is currently going broke, right? ICER, or incremental cost effectiveness ratio, is probably the principal metric. Can the country afford robotic surgery or not? And the incremental cost effectiveness ratio is done principally by three items. The clinical benefit is going to be survival and quality of life. And in thoracic space, I don't think robotic surgery or how we do the operation differently will ever influence quality of life or survival. And none of the studies show that. So it boils down to cost, really. And what are your thoughts of that? 99% of all the robotic operations in the world, the costs are being determined by one single company in Sunnyvale, California.
Yeah, I think that's a very appropriate question to ask. Two elements to that. One, which is should there be a wider variation of robotic platforms? And I think there is no question that having a safe set of wider platforms, but competition is only a healthy thing. But it is a very high bar to reach because there are other companies in this space, as you know, other than those in California. But to get the same level of exactitude and usability has proven itself not to be easy, despite the patents going out a few years ago and people trying to replicate what's out there. But I think it behooves us to, in the world of advanced analytical capability, artificial intelligence tools, there needs to be a new set of platforms. And so my argument, and I work in industry, is we need to be better at that, and that's one thing. In terms of in the UK financial ecosystem is like, as I presented, I think the metrics of survival or the metrics of simple length of stay are not quite appropriate for the outcomes that we're looking at. If there is going to be a joined up approach to health and social care in this country, and I'm not trying to make a political statement, then there needs to be an appropriate appraisal of how these tools actually work, rather than very abstract. It is an important outcome, but it doesn't tell the full story. And so choosing our outcome metrics is going to be the big determinant of health utility in the next 20 years. And I would argue that as leaders in this space, we need to discuss this with our policymakers to push harder. I know for one, I've said to NICE that I think that it's too heavy-handed just to have 2 or 3 metrics of success where it actually doesn't really capture reality.
So I love the HTA reports. I think they're much more objective than clinician-led research. And the Welsh HTA report, thank you for highlighting that, showed that robotic surgery was not cost effectiveness in Wales. And I think this is interesting because we're still doing it. So I think the world is like charmed or caught on the charm of the whole robotic wave of thoracic surgical enthusiasm, that even though it's not cost effective, if it was a drug, right, it would be stopped straight away, right? It would be like, you can't prescribe it anymore. I'm sorry. As of 1st of September, that's it. It's done. So why do you think we have such fascination or such leeway for thoracic surgery, despite health authority boards themselves declaring it not cost effective?
So I'm going to be mildly controversial, Eric, because I can be, I guess, because we're amongst friends, right? The reality is that a lot of our thoughts of HTA were designed for pharmacological interventions, and that even, in terms of medtech, a lot of people have been using pharmacological level grade. This is a phase 1 study, this is a phase 2 study. They've been using the pharmacological playbook to address things, which is fine to an extent. But actually for medtech and for actually a lot of interventions, those tools haven't necessarily been designed to address the actual value statement of some robotic surgical and other surgical modalities. And as a result, you will find that, for example, even before RCTs came out, in terms of equipoise, when people were looking at prostatectomy versus, robotic versus open and laparoscopic, they realized without having an HTA that this was working better for their patients, and the adoption was almost independent to the HTA. And the HTA then came in afterwards just to kind of maybe let's prove a point that it is cost effective or not. And you'll find that the reality is that we have somehow, as an international community of people working in the cost effectiveness space, have sometimes done it post hoc rather than prospectively, because actually innovations move faster than we've been able to work with the technology. And one of the major presentations I like to say after all looking at this umbrella review is the world of cost-effective studies is still in its infancy. So there are a group of people who are able to do it, but the data that they've been given is still actually very primary and requires a lot more granularity, and we haven't got that yet. So I would argue that we need to engage with health economics even more, because the health cost-effective studies so far need to improve by manyfold. Just like our adoption rates have improved manyfold, we need to be better at giving the data for cost-effective studies.
And excellent. And whilst we're being controversial here, I'm going to make an even more controversial statement. From a care perspective point of view, is it cheaper to burn out surgeons' backs and bodies and then get them to retire than to actually pay lots of money on tech or equipment to help prolong their lives or their working lives, so to speak?
I mean, the reality is no one has incorporated the surgeon as a metric or a variable in their analysis, right? So no one cares. It's considered just a box surgeon, outcome. Then no one has actually considered, how the surgeon is, how many more cases they can do without having to go to see a physiotherapist or a chiropractor or something. That is a thing. And actually surgeons are athletes. They are. You're like world-class athletes. When you see the World Cup, you're seeing all these people who get regular medical assessment, and their optimization is important. You guys are saving lives. You guys are doing things. That needs to be part of that assessment tool, and I think it has been totally ignored. And I think that is one new variable that we, at the very bare minimum, need to include in these analyses.
Excellent. Thank you very much for a very fascinating presentation today. Next week, we have the world famous Diego Gonzalez talking to us about single port robotics. Please to thank our sponsors, AstraZeneca, Medtronic, Medela Science of Care, and once again to you, Hutan, for a very special presentation today.
My pleasure. Good to see you all. Take care.
Thank you. Bye-bye.